For the final bit of time we have here, we're gonna do another one of these unique talks. So Yeleni and Pat Reardon, please come up. We're gonna talk about is it possible to standardize the fundoplication, a review and discussion of technical variations and evidence to support common teachings. You guys are welcome to do it any way you'd like, sitting, standing, however. You... Perfect.
I appreciate being asked to come talk about something that we've been doing for about almost a quarter century now. So the big green one goes forward?
Yes.
I have no financial disclosures. I wish I did, I don't. And so talking about how to reproduce, make anti-reflux surgery reproducible for large numbers of people. Because for the majority of people, I think it's all about art and gestalt, which is hard to teach. I thought I'd put this beginning. Videos of how we do it are in the SAGES library and SAGES programs, but on YouTube, you can see the stuff we made for our fellows, which is incredibly detailed, way more than you can have in a little short video. But we have one of the oldest fellowships in the country, heavy foregut, and so one of the first things we tried to do was figure out how to make a teachable technique for all our fellows. And we want to end up with a wrap that's consistent and reproducible no matter who does it, because if it takes you 10 or 15 years to learn the art of it, then it's not really going to be very beneficial. And so at the time, we were already using a suture, pardon me, attached to the posterior fundus, because if you try to have a fellow pass it around behind with an instrument, they dropped it a lot. And so actually one of my fellows, Juan Marti, said, why don't we put a stitch there? We cut it long, and you can always pull your wrap around. So if you don't want to measure like we do, I recommend this technique, especially in teaching programs. And then I had a fellow in 1997, and the problem was every time he did it, he would grab a point on the posterior fundus that didn't work out. And sometimes it's that really low grab, like you saw in that picture of the bad fundo, right? You don't want to pull the body around. And so he wanted to know, well, how am I going to learn where to grab? Because you get the right spot all the time, and I don't. And so he actually asked me that question on rounds, and we literally pulled a piece of copy paper out of the copy machine at the nurse's station and sat down and started, jotting. These are my notes for, well, what is it that makes up a 360 fundo? I stuck them in a drawer, and I still have them. And when I was a 4th or 5th year resident, this paper came out, and, there were no videos to watch for trainees, so this was an awesome article with good science and incredibly well illustrated. But the important thing to look at is that right there, because that's the first time I ever thought about the concept that a 360 fundo is a cylinder and a cylinder. That's what the operation is. And Paul Jordan was one of my strong mentors, and we used to just take the bougie and we would dunk it. And that way he said, look, we didn't change the configuration of the fundus. The short gastrics were still aimed over there at their origin and the spleen, and we would just push that bougie down into the fundus to make our wraps. And so we just started with cadaver work, and these are the definitions we used. And there used to be a lot more autopsies, and we would get a fresh unit from the esophagus through the duodenum. They'd give it to me. You'd run down there with our 60 French bougie, and we built Dr. Demeester's operation, minus the internal pledgets, right there on a table. And I recommend if you've never, because young people maybe never even do open ones, but even if you've had the experience, you've never built your operation in a fresh cadaver and then deconstructed it, you ought to do it, because that's what we did with Dr. Demeester's operation. So we built it on the back table, and every place we put a suture, we marked. We marked where the short gastrics were, where they met the posterior esophagus on the left side, and basically we reverse engineered his operation. And I will tell you that when we took it apart, the places where your stitches go are not in a place I ever would have guessed that they would be. And so what we did was we had these marks, and so we initially measured down, well, look, it's 6 centimeters from the GE junction, and then I just measured radially out to the fundus, and that was 6 centimeters. Turned out it was 6 centimeters to get back to home. And so we decided, well, this seems, we did it in 6 cadavers, always the same, makes sense. And we were, mind you, I put a finger in there, because that's how I learned, and my finger measured 1 centimeter, so that was the gap in between the 2 cylinders. So we actually took this into the OR, and so we did 250 people, and it can't be right because no matter how big you were, we put a 60 French bougie in because that's what Dr. Meester said, but we did it. And then I personally took a plastic ruler and I measured the circumference of that esophagus. So for you young people, that's a 720 by 480 image. Yes, that's what we used to operate with laparoscopically when we started. We didn't have 4K. A little bit of jaggies going on there. But as it turns out that, using these things worked for us. And the real concept is that, going back to Dr. Meester's operation, the looseness or tightness of your wrap has to do with that gap between the bougie-filled esophagus and the completed inner circumference of your fundoplication. And then if you look over there, the points we chose, that's how they go. And when you pull them around the front, you get your completed fundo. And this is the data, and it's really interesting because we talked a lot about 270s today. And when I started doing 270s, we made them over a 60 French bougie. Well, males and females, the average circumference is 8 centimeters, which means with a 60 French bougie in place, you need a 2 centimeter gap in the front. That's exactly the one cord you leave out. But people leave that and they don't put a bougie in, right? And it's not a 270, it's closer to 180. And as you might expect, if you measure the characteristics of physiologic characteristics of a person, that's our bell curve for the circumferences that we measured in those 250. And it turned out there was a really strong correlation with your age and your weight and BSA, and it resulted in this regression equation. And so we began to use that. And initially, all I did was make an Excel file that I locked. And you'd put your values in, and when you pushed a button, you'd get 3 different circumferences, one for a loose wrap, one for a medium wrap, and one for a tight. And that's 9 millimeters of gap, 6 millimeters of gap, and 3 millimeters of gap. Now, we actually have an app that you can go get off the Android or Apple store. And the way it works is you put this information in, and we take it right out of the chart. Height in inches, weight in pounds, age. You hit the calculate button, loose, medium, tight. It also calculates the diameter to which we close the hiatus. That's equal to having a 60 French bougie in, pull it out, and add 1 pledgeted suture, which is what we were doing. And my partner has learned to use an endoflip, so we can now see what our endoflip values are, the way we do it, and how it calculates compared to people who've done it, where they're closing it based on their resistance. And so other people have replicated this. This is from a study done in Japan. One of the first things they teach you, if you're going to try to use someone else's data, does the population compare? In Japan, the answer is no. Japanese people are not as big as Texans. In our study, we had 1.6% of people who were so petite this didn't work because your little ruler went out into space because the stomach was so small. They had to redo their numbers. And then another group has done it. You can see they've exactly copied our technique and gotten good results. And we can skip any video, but that's really all I got to say. Like I said, if you want to see in detail, it's on our YouTube site that we make our fellows look at, because if you don't know how to do it when you walk in the room, you don't get to do it.
There you go.
That's all I got to say.
So I know this was intended not to be a debate and pick sides, but I think you can clearly see there's probably sides here. I had just one slide I wanted to show as well. And so I think it's, really nice that you're able to have this replicatable technique with the Nissen fundoplication, but, I have no relevant disclosures. But what I wanted to, point out, just looking at the session today, I think that already makes the point for me that when we talk about standardization, what do we mean by that? Because even as a group of experts, we can't even agree, on whether we should be doing a toupee or a Nissen. Should we use a bougie? Should we use the endoflip? Should we be doing, TIF or links or fundo, or what should we be doing? And as Lena and Prakash nicely demonstrated, there's a lot of personalization when we talk about how we're doing these plications, what we're doing for the patient. And I know, I think gender and age probably play a role in that in BMI, but I think there's more to it, when we're talking about the physiology of the actual lower esophageal sphincter, the esophageal physiology. So I think it may be more than just the physical aspects of where we're measuring, how the fundus is coming around, where exactly the stitches are, how you put your stitches. Do you put an anterior stitch to the crura? Do you put a posterior? Do you do a hunter stitch? Do you do this stitch? Does it matter? I mean, if we're all, doing a lot of these operations, I think that's the most important thing. If you're comfortable doing these fundoplications and you look at your outcomes. But I guess the question about how do we standardize it, I think we have to better understand what we're doing physiologically too before we decide one technique is better than the other. But I agree, in terms of being able to reproduce your own technique, I think is important as well, no matter how that is.
So we're not reproducing our technique. We're reproducing Tom DeMeester's, which at the time was the gold standard. And personally, I think you ought to go do what we did. Go in the cadaver lab. If you're doing yours different, go analyze how you actually created that, because otherwise you just tell people, do what I do, watch here. I can personally tell you from my open experience, that was really hard. They would always say, put your hand inside this wrap and feel how tight that is. That's how tight you need your wraps to be. As if your index finger's got some tensometer in it, and you're going to be able to accurately reproduce that. And so the reason we did this is because it's very reproducible. To do a 270, the right side of the fundal gets sutured down exactly the same. The left is over 1 centimeter. And we don't give everybody anything. On both the cases that Lena did, I would have offered both those people, we tell them you can have a Lynx, you can have a 270, you can have a 360, and here's the advantages and disadvantages of all of them. And so we offer everything. We just try to make it reproducible, because for trainees, it's super frustrating to have people just say, watch what I do and reproduce that.
Yeah, no, I mean, I think that good points. I think there's probably no right answer here what we're doing, but I think, as you guys nicely put together this session to demonstrate, there's just so much variability in terms of what we all are doing. And, the first talk about, call to action, this is probably a call to action to everything we do, not just how we diagnose and, how we categorize the patient population, but what are we doing technically and how are we deciding what to do?
Yeah. When you guys close the hiatus, how do you judge how tight it is? Like, what are you shooting for?
I do use EndoFlip intraoperatively, and so usually use my visual cues and then check that with the EndoFlip, just like Mike does. I do measurement after I've reduced the hernia before I do my closure, and then again after I close. And so if it looks too tight on the distensibility, I will take a suture out here or there, or if it's a little bit too distensible, I'll put another stitch in before I continue on.
We literally just put the numbers in the app, and we actually put a plastic ruler.
You still measure it?
Close it to the whatever diameter it says it should be.
Okay.
But my younger partner has learned how to use the EndoFlip so that we can compare our outcomes. Because the question is, do you need an EndoFlip?
Yeah.
Because we have people doing that in our building, asking, when you get done, why don't you just measure what your final AP diameter was?
Yeah, why would you not put that into your algorithm since you're actually calculating all those other numbers?
Well, and so, like I say, there are people in my building that every day measure the EndoFlip, and they're using the numbers between 2 and 3.5. I said, well, put a ruler there and tell me what your final AP diameter was. You do 50, and it's all reproducible, so you can skip the business with EndoFlip, right? Just leave a step out of the operation and speed it up. Right. But right now, they're reluctant. I can understand it, because if all your research has to do with the EndoFlip, and it turns out you do 50 and you don't need any more, then you got to go find something else to do.
Right. Do you guys fix the fundoplication to the diaphragm at all? Do you do gastropexy?
I do not. Yeah. I do not.
I do. Despite the data that says that it doesn't make a difference, I fix it.
And do you factor that into your computer generated algorithm as well?
No, I mean, so you just tell the fellow, see back there, put a stitch where it touches the diaphragm. And that has no science at all behind it. That's because Dr. Jordan always put posterior gastropexy sutures, and so that's the lowest level evidence.
So that's really interesting to me, because you've got a lot of science, a lot of measuring going on, and now you've got a pexy stitch that's got no science behind it.
No, just you feel good doing it.
Right.
For sure.
I wear a red hat every day in the OR for the same reason.
Oh, awesome.
How long do you guys try to make the wrap? You shooting for it?
Usually shorter, around 1 to 2 centimeter wrap. But I usually do. I've kind of switched a lot to toupee now, so I've moved away from Nissen.
And Yeleni, just to add a little spice to that, what made you switch to the toupee?
I mean, the data is compelling to me. Sure. And, especially with those large paraesophageals, when you're doing those, older women that already have a shortened esophagus, have had, all this dysmotility from, I don't see any reason to do a Nissen, in my opinion. I think a toupee gets them what they need, especially you're talking about reflux. But even when we talk about reflux, the data is very compelling. And so to me, I don't, why take the risk of the Nissen if it's not necessary? So I will, again, personalize it based on what the patient's desires are and outcome they want as well. But moved most of my practice to partial fundoplication.
And I ask this for both of you, what do you do, in this age of internet accessibility? Patients come in and they tell you what they want and they've really researched it. How do you manage those patients when you know, for example, they should not have a Nissen?
Yeah, I mean, I think usually the case is when they come in for links and they're not appropriate for links. Usually it's easy to, I have probably a patient population that's easy to reason with as well. And so as long as you explain to them, why links is not a good option for them, I think, or if it's a Nissen or whatever it is, I think they do understand that. But yeah, I don't know.
Links are the patient population who have a preconceived notion in the highest proportion of patients. They come in, they want a link.
Yeah.
Right.
And I just look at their data and advise them based on that. The next most common situation is someone who's been told, particularly about older GI people, never get a 360. Your life will be miserable from gas bloat. I do tell them that I think that in my hands, their greatest long-term control of GERD, documented by pH, would be with a 360. But what you're going to roll the dice on is you got a 25% chance you're going to say you can't burp, you can't vomit, and you're going to complain about being gassy and bloated.
All right, well, I'm going to wrap it up with that. I know we're a few minutes late. I appreciate you guys doing that. And
Thank you for this great session.
Yeah, thank you very much. I apologize that we ran over and that we didn't have time for questions, but I thank you all for sticking around so late. Great job, guys. Thank you.
Thank you.
Thank you for my water.